From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. Today, I am speaking with Dr. Seema Khan, who's a professor of surgery at the Feinberg School of Medicine at Northwestern University, about the article with the topic of double-blind presurgical trial of oral tamoxifen versus 4-Hydroxytamoxifen in women with ductal carcinoma in situ. Dr. Khan, welcome. Thank you for making time for this.
I'm very pleased to be here. Thanks for the invitation.
I find there's usually a good story behind why investigators pursue a specific line of inquiry. And so I'm curious about why you wanted to pursue this particular work, looking at oral versus transdermal tamoxifen in women who have ER positive or estrogen receptor positive ductal carcinoma in situ, or DCIS.
That's a great question. I would just start by saying that the DCIS that we chose to focus on, that entity, was being used in our trial as a model for cancer prevention. So women who have DCIS, this is in situ disease, the cells are inside the duct, so they cannot travel to other places. And the main purpose of treating DCIS is to prevent invasive cancer in the future. So this is really a prevention model. And our focus has been on breast cancer prevention for quite a while. And one of the sort of main issues in breast cancer prevention implementation over the last 25 years has been that the landmark trial by the National Surgical Adjuvant Breast Group, the P1 trial, which tested oral tamoxifen against placebo and showed a 50% reduction, a halving of the breast cancer risk in women at increased risk. That trial was expected to lead to strong implementation, acceptance by many women, because tamoxifen was considered to be a low toxicity, well-tolerated agent. That turned out not to be true. And so 25 years later, we're in a position where oral tamoxifen is being declined by about 85% of women who would benefit from it. So alternatives were needed. And for a variety of reasons that I can't get into now, we had gotten interested in the idea of transdermal delivery of drugs to the breast. And this is based on the fact that we've known for a long time, for the past century or more, that the breast is a skin appendage. And we have learned recently that it has a very well-developed internal lymphatic circulation, and that drugs applied to the breast skin reach good concentrations in the breast, but very low concentrations in the circulation. So this seemed to be an approach where one could deliver drug to the breast where it was needed and avoid exposure of the rest of the body and therefore avoid side effects. So that was the reason for wanting to do the trial, and DCIS was the perfect model because we expect hormone receptor positive DCIS to respond to tamoxifen.
Will you please talk to us about the biomarker that was selected as the endpoint for the study? I am not a specialist in breast cancer by any means, and so I am curious what we already know about Ki-67 and its importance in DCIS.
Right. So it's really important in trials like this, which are short intervention trials where we cannot watch for the occurrence of a new cancer, and we use what's called a surrogate endpoint. So something that will change in the direction that tells us that cancer would likely be prevented. So for that purpose, Ki-67 is actually very well established in the breast cancer world, more for invasive cancer than for DCIS. But, if something works for invasive cancer, it's very likely it'll work for DCIS. But Ki-67 measures cell proliferation. So dividing cells express this protein. And so the intent was to measure the rate of cell division in the DCIS lesion and to show that the oral tamoxifen would achieve a reduction in cell proliferation using this marker. That was expected, so that's the positive control arm. And then we were testing against that positive control this newer approach where we were hoping to see non-inferiority. So we were hoping to see that the effects on Ki67 or cell division would be similar between the two treatments.
Thank you for that, because it's obviously important background for the work that you all have done. I am going to put a note for readers in here that I really want to encourage the readers to spend some time looking at the e-supplement on the methods, because there is some really important information in there that's mentioned in the discussion, but is presented obviously in more detail, and I would hate for them to miss that. I would, however, love for you, Dr. Khan, to share with our listeners the process that you all worked through with the changes to the trial protocol and trial outcomes. Because when I was reading the supplement, I saw those and I thought, wow, this is not a decision that I know was made lightly by the investigators. So I would love to hear more about that.
So that's always a challenging process. So when we design the trial, we try to anticipate the characteristics of the population that we are hoping to enroll in the trial, and to make the trial inclusion criteria broad enough that we will have a wide funnel for participants to enter the trial, but to make them selective enough that the results will be scientifically rigorous and that we will not include populations for whom use of the agents that are being tested in the trial will cause a hazard. So it's a question of finding the right line between safety for the participants and scientific rigor and pragmatism, in the sense of having a wide open funnel so that most women with the condition would consider participation. So this process that we went through, so that's how we set up the trial. The first thing that we changed was we wanted to do a 6-month intervention, so we would actually be able to measure a decrease in the size of the DCIS. That did not work out because most women are unwilling to wait that period of time to have their DCIS removed. And we had very low accrual in the first 6 months of the trial, and it was obvious that we needed to rethink it. So we went to this so-called window design, where the treatment is much shorter. We had a treatment of 4 to 10 weeks, and that was the interval for many patients between the initial surgical consultation and the date of surgery. So that was sort of the natural interval that many women would wait anyway. And so that became a lot more feasible. It meant that we couldn't use the size of the DCIS. We would have to use this surrogate endpoint of Ki67 that we've just discussed. And then the second thing was the inclusion of, we had to make various decisions about how we were excluding women who had been on hormones prior to entry into the trial, because withdrawal of hormones, which many women do when they're diagnosed with DCIS, they stop their estrogen medications that they're taking either for contraception or for menopausal symptoms. And that cessation of estrogen will cause a decrease in the Ki67. So we didn't want women to be going off their estrogen treatment and starting the trial treatment at the same time, because that would alter the response. A lot of the response could be coming from the estrogen cessation. So we had to, try a few different variations of that in order to make it still retain the scientific rigor, but increase the flexibility of the trial. I think those are the two main areas that we had amendments in. The others were mostly, technical feasibility, things like that. But that's always the balance that everyone who does clinical trials is trying to achieve. And it's sort of the art of the clinical trial design.
It absolutely is. And that's why I like to ask that question about the process, even though it's something that's not obvious, because I think it's important for investigators who are in the learning phase of how do I do a good clinical trial to understand that even really experienced clinical trialists sometimes have to back up and recalculate the route that they're taking to get somewhere.
That's certainly true.
Why was it important that you use a non-inferiority design for this study? I love non-inferiority studies. I remember first learning about them a long time ago and thinking, gosh, this is genius. But why was this important for your study in particular?
Because oral tamoxifen is the current standard. So anything that is introduced as an alternative to oral tamoxifen should really provide equivalent results. And so it's a challenge again with a small trial like this to show non-inferiority, but we designed it to the most rigorous degree possible with this kind of sample size because this is a phase 2 trial. We had hoped to go to a phase 3 trial based on the results from this trial if we could show non-inferiority. So those hopes were dashed, obviously, but showing lack of difference is not the same as showing non-inferiority. The statistical testing is quite different. The goal is to show that the new medication is within a certain range of what the standard medication achieves for the same purpose.
Your final evaluable group that you had didn't quite make it to the mark of the 80 patients that you all had calculated that you needed when you did your power calculation at the beginning of the study. Do you think that this small gap of just a couple of patients impacted your results at all, or was the difference between 75 and 80 patients probably not a factor?
It's not only that that's a small difference between 75 and 80, it's also that we were sadly quite far away from showing non-inferiority. So, if we had been like this close to showing non-inferiority, that might have played a role. But, I think sometimes clinical trials involve interim analyses for futility. We didn't have an interim analysis for futility, but I think if anyone thinks about doing a larger trial, our results hopefully would be helpful to them in that, they can at least exclude the sample size required for the final effect that they're hoping to see, because this was, I think, definitively not non-inferior.
Right. I am always really curious to hear from investigators what lesson they learned in a study. And so what for you was the biggest lesson that you learned in either designing or conducting this particular study?
We learned several lessons, but I think the most important one is that in this general approach of transdermal drug delivery that we've been interested in quite some time, and is it's very intuitively attractive to women. So we get a lot of interest from women in wanting to use a drug gel applied to the breast skin rather than taking a pill. So, I think that's in line of investigation that will continue. Certainly we're continuing it, and hopefully others will too. But in setting up a comparator to an oral medication, the fact that we did not consider strongly enough is that oral tamoxifen and many other oral medications have several metabolites. So from the gut, drugs travel to the liver, and in the liver, they're broken down into several metabolites. And tamoxifen is actually a prodrug. So when tamoxifen is delivered to a petri dish, for instance, of cancer cells, or, in a situation where it's not going to be metabolized into its active components, it has very little effect. The activity of tamoxifen really comes from its metabolites, and there are two important ones. One is the 4-Hydroxytamoxifen that we used in this trial, and the other was discovered later and is called endoxifen. So we were actually very fortunate in being able to measure tissue concentrations of both 4-Hydroxytamoxifen and endoxifen. And what we learned is that the endoxifen generated that ended up in the breasts of these participants was many times larger quantity than the 4-Hydroxytamoxifen. So it actually had the dominant effect. And the gel participants received only the 4-OHT, and the 4-OHT concentrations in the two arms were not very different, but the oral tamoxifen group got this extra big whoosh of effect from the endoxifen. And there's been more work. I mean, we designed this trial in 2015, and there's been more work on endoxifen since. It seems like it may actually be a more effective metabolite than 4-OHT. So we're currently engaged in trying to develop an endoxifen gel, and we're hoping that that's something we can test and it'll have better efficacy. There are also theoretical reasons for thinking that endoxifen will get through the skin better, which will also be an advantage. So I think the next thing we need to do is really use a very potent metabolite and then also be able to deliver it through the skin in larger quantities.
I like that. You mentioned that this was essentially a negative study, that the non-inferiority of the transdermal formulation that you all selected for this study could not be established. Where does this point you for your next investigation? Is that going to be going with the more potent metabolite of the drug, or is there something else you're thinking about as well?
So we are, as I said, working on developing an endoxifen gel using different technology than what has been used so far in the gels that are available. But that'll take a little time to develop. In the interim, we're still focusing on the idea that we have to make tamoxifen more, or similar drugs, more tolerable to women. And a very important concept in prevention medicine is that we should not keep doing what we've done historically, which is borrow dosing from the therapy trials. So, therapy trials, when drugs are developed for treatment, the general approach is to demonstrate the maximum tolerated dose, because the idea always is more is better. And this trial on the transdermal delivery has given us some interesting data. And we actually have just completed a different trial that is also adding data to that, is how little is too little. That's the approach to use, not how much can a person tolerate. And so that's minimal effective dose. And actually, big strides have been made in this area by a group in Italy led by Dr. Andrea De Cenzi, who's a medical oncologist. And he has published a couple of years ago a trial on low-dose tamoxifen where he used 5 milligrams rather than 20, and found that it was remarkably effective for being a quarter of the usual dose. But that dose was not as effective for premenopausal women. So now the study that we'll be starting hopefully early next year will be a trial where we are trying to find the right dose for premenopausal women. So premenopausal women who would benefit from tamoxifen for prevention will start a 5 milligram dose, and then 6 months later we'll check their breast density, because breast density has been very well shown to reduce in women on tamoxifen, in many women, not all women, but many women on tamoxifen. And this is particularly true for premenopausal women. So we're going to use, instead of Ki-67 as the surrogate endpoint, we're going to use density as the surrogate endpoint. And among women whose density doesn't decrease on the 5 milligram dose, then we will escalate the dose to 10 milligrams and then check again. And if the density still doesn't decrease on 10 milligrams, we'll offer them 20 milligrams. So this is actually a novel concept in cancer prevention, is, patient stratified, individual-based risk as dose escalation using a surrogate endpoint. And so I'm pretty excited about that trial. I think it's breaking new ground in prevention. And many of my colleagues are as well. So we have 10 participating institutions. And everyone I spoke to about the trial was very enthusiastic about being part of it. So we have funding for the trial from the National Cancer Institute, but also from the Breast Cancer Research Foundation. And so, we're just gearing up to launch that study. And hopefully we'll see results from that in 2 or 3 years.
Sounds like lots of exciting work to come from you and your group yet. Dr. Khan, thank you so much for taking time out to speak with me today. I think this has been a really helpful conversation, both in terms of learning about your science and in terms of hopefully providing some education to folks about clinical trials and why they're not nearly as easy as we want to believe they are.
Yeah, well, I enjoyed talking to you. Thank you for inviting me to do this. And I'm really looking forward to the reaction to the study, although disappointing, we did learn some important things.
Absolutely. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.